about weaning off the ventilator and then putting them onto oral fluids. Next. Now, as I said, the recent ones approaches are little bit different, which high frequency oscillatory ventilation, liquid ventilation, of course pulmonary transplant, anything does not work, transplant. If liver is not functioning, after some time you get fed up, you say to transplant. Now, in terms of recent advances with antenatal diagnosis now, not here but abroad, they, as I said before, they used to do fetal surgery, where they used to operate on a half-formed fetus, they used to deliver and do it. Now they have become even more super specialty. They do a bronchoscopy of the fetus. Through the abdomen of the mother, they go into the uterus of the mother, then they open the mouth of the fetus, they push in the bronchoscope into the trachea of the fetus and then plug it. So it's called plug, L-U-G, that is plug lung until it grows. So what the theory is that diaphragmatic hernia lungs are bad because they don't expand. And there is a lot of fluid, amniotic fluid is coming in and out of the trachea. So what their contention is, if you do not allow the tracheal fluid to come out, that acts as a stimulant for the lung to grow. So to prevent the tracheal fluid from coming out, they block the trachea with a balloon. So now the fluid cannot come out, the fluid stays in the bronchi and the bronchioles and the thing, and therefore it helps the lung to grow. And then just before birth, or just at the time of birth, they take out the balloon, and then hopefully by then the lungs have grown to an adequate level, and then, as I said, stabilize the child, then operate, do the hernia defect, etc. Next. So as early as 17 weeks, by a good sonologist, we have been able to pick up diaphragmatic hernia. Next. Again, we have to keep ourselves on the ground that don't think we are God. We can make errors. We can make mistakes. At times, congenital cystic adenomatoid malformation has been mistaken for a diaphragmatic hernia. A leiomyosarcoma has also been mistaken as a liver going up into the chest with a diaphragmatic hernia. It was a lung tumor. Mediastinal teratoma, even the side of the hernia can be deferred because the heart is shifted on the opposite side, so you don't know which is left and right. You may make a mistake. Antenatal. Postnatally, you take a proper X-ray with the proper markings and you are not likely to miss the side. Next. Okay, prognosis-wise, there are a lot of things which make it worse or better. Management-wise, what we can do in India today is try and transport the mother to the facility where all the neonatal surgery, ventilator, NICU is ready. You imagine today in Bombay, a patient is born somewhere in a nursing home in Mulund and then is transported to, say, Harkisandas or Wadia hospital, wherever. It's much easier to transfer the mother when she is still pregnant to Wadia or Harkisan or wherever, have her deliver here, so that as soon as the child is born, we are standing in attendance. Immediately child is shifted to NICU, started the stabilization procedure. So it's better to transport a mother in distress rather than a newborn in distress in a critical position. Next. Again, prognosis-wise depends on preoperative, whether it is unilateral or bilateral, when the child has presented, if it has not been picked up antenatally, what are the contents. Liver in the chest is a poor prognosis. Chest X-ray score, which I have not talked about, blood gas results, ratios, AFT, stature volume, all there are multiple parameters based on which you can say this is a good or a bad prognosis, which is what you need to convey to the parents. Next. Intraoperative, of course, if it's a large defect which cannot be bridged, then you have to put in a patch. That is a good poor prognosis, or there is no sac, therefore the lungs are completely, the bowels go right up to the apex of the chest, which is again a poor prognosis. Again, if you see liver in the chest, it's not a good sign. Post-operative, again, blood gases, etc. In spite of a good ventilator, if you are not able to maintain the blood gases for a period of 2 to 3 days, this child is going down. Next. Surfactant has some value, Not in all cases of diaphragmatic hernia. They thought that this was a wonder drug at one time for diaphragmatic hernia. Now they are coming down saying that no, in few cases it may work in diaphragmatic, not in other cases. Other cases surfactant has done a fabulous job. Next. Again, as I said, these are the antenatal therapies which are available outside. We don't do any antenatal invasion. All we do is counsel the parents that this is what your child has, this is what you can expect, this is what we can do as of now. And if it is already beyond 24, 28 weeks when the child is detected, obviously there is no option of termination. So therefore we just keep doing at regular intervals. MRI can be done on the fetus to look for the lung volumes, which may give us some basic prognosis. Next. Okay. So this is what is diaphragmatic hernia. So basically that is one part. Second part I wanted to talk is about empyema. See, the point is empyema is basically due to the lung problem. That means either a pneumonia which has gone into empyema, a lung abscess which has ruptured. So from inside out or outside in. Outside in is usually trauma or any surgery done, following which the child develops empyema. Now if there is empyema, there are two approaches today in our country. One is minimally invasive surgeon being maximally aggressive. So they say any empyema, do a thoracoscopy. It's called video assisted thoracoscopy. So that is VATS. So I say patient ko VATS lagi. Because for every patient of an empyema, you cannot do a thoracoscopy and clearance. Many of them may suffice by just putting in a good intercostal tube and draining the whole empyema, giving adequate antibiotics, looking at chest physiotherapy, and observing them over a period of 3 to 5 days. If they start showing signs of improvement, there is no problem. When you say there is no improvement, A, if the fever persists, B, the counts are high, C, there is persistent drainage after 5-6 days, a whole lot, then you are in trouble whether the empyema is really responding or not responding well. In those cases, yes, I would go in for what is known as a decortication, which means there is a peel which has formed, there are multiple loculi which are probably there, which will be seen either on plain X-ray and or the HRCT. And in those cases, yes, no hesitation, go in and do a decortication to save the lung. But again, as I said, if the lung is bad, no matter what surgery you do, if the lung does not recover with your antibiotics and whatever surgical procedure, you are not going to be able to do a good result to this particular child. So be careful when you see a pleural effusion which may be showing lot of pus cells, etc. Rather than doing just a aspiration with a needle and syringe, put in an intercostal drain, a big one, let the whole thing drain, give antibiotics, maybe do a culture, wait for the culture report, and then change the antibiotic if the antibiotic you have already started is not adequate, and observe the child for the next few days. If the child's spike goes away, the counts are coming down, the drainage is coming down, the chest is clearing on a plain X-ray chest, then you know that you are on the right path, you need not do anything further. If any one or more of these things is not happening, then get an HRCT done, see if there are multiple locules, see if the lung is bad, see if there is a thick peel which is seen. If that is seen, you have no other option but to go in and do a decortication. Any questions?
So what about plug vessels? Any results regarding plug?
Plug is being done only in 1 or 2 centers. One is at San Francisco, one is in Buffalo. But they have not been able to successfully say that yes, plug is making a lot of difference in survival. No. The same patients or similar patients who have been born and stabilized and then operated are having similar results. So plug is not really making that much. So in certain centers they are withdrawing. See, we have a good advantage that we learn from their mistakes. We don't make the mistakes. Same thing happened in hydrocephalus. Antenatally, they used to say do a ventricular amniotic shunt so that the hydrocephalus, the dilated ventricles go down and therefore everything will be fine. But neurons were still being born after that. So then they said, no, now stop doing it. Let the child be born, then you do a revision. Because when you are doing these intrauterine procedures, you are endangering two people. When I operate the newborn, I am only endangering the newborn if at all. The mother is pretty safe. Here you are going to do, somebody tried doing a vesico-amniotic shunt for a posterior urethral valve in Mumbai some years back. They put the catheter into the bladder, the other one was in the amniotic fluid. 2 days later the child had to be delivered because the mother went into premature labor. The child was born, the shunt was in the peritoneal cavity, not in the bladder. Child was operated, went into sepsis, died. So what I am saying is, I am not trying to criticize or say that this is wrong. It's a fantastic thing what they are able to achieve. But we have to be scientific and say that does this make a difference, and in which selected patients that this difference is really going to be a good difference, that yes, we should start doing it on a routine basis. If you are not convinced, if the results are the same, whether you are doing intervention and then delivering them or delivering them and then doing the intervention, stick to delivering them and doing the intervention and be happy that okay, we have learned from their mistakes, they made the mistakes, these children are benefiting. Because unnecessarily these children may have been going into intrauterine and unnecessarily they would have had the same result.